it is very well said that incisions are not that important as decisions, and decisions are more important than incisions. I'll just show you what is the controversy in topic like pink pulseless hand. So my worst cases was not so pink pulseless hand. So 6-year male presented at my hospital 10 hours after injury with a backslap like this, with a note that there was no radial pulse was absent, there was mild delay in capillary refill, and all the nerves were normal. Okay, I need volume in this. Yeah. Okay, so this is how it was. This was the capillary refill. You can see it is delayed. It is slightly pale. Okay, no, here, next slide. Yeah. So this is the handheld Doppler I spoke about yesterday. I am checking on the radial now. There are no signals. This is on the ulnar side now. This is after anesthesia. This is at the middle of the night. You can see there's a pucker sign, but there are no signals on table. And this is his on-table pulse oximetry. The vascular surgeon was asked to remain standby, and this child was posted for close reduction and internal fixation. So there was no. So this is how I could get the reduction. This was the fixation, near anatomical fixation. This was immediate post-op. The signals which were absent started coming up, but not so well. But at least there was some plethysmography which was there. So I informed the vascular surgeon that I am not very happy with the circulation. But when I waited, everything started falling in line. The saturation was normal. The child woke up, had normal movements. And then I called him up that what should I do? I'm not getting still the pulse on Doppler. So he said that I'll see the child tomorrow at middle of the night. We don't need to do anything because pulse oximetry is normal and capillary refill has improved. Next day, I made a mistake of putting this case on our group. And the first answer was waveform present on pulse oximeter. What is the saturation? Is that hand perfused or not? Pulse not so important. Have to watch compartment syndrome. Doppler may show arterial injury, but if the collaterals are good, hand is perfused, no indication to explore. So this is proximally lateral. If reduction is good, milking open or less, it's not there. Some journal articles. Then for me, this is an indication of Doppler ultrasound or CT angio to document collateral circulation and reperfusion. That was opinion by a pediatric orthopedic surgeon. If nerves okay, look, that was another pediatric orthopedic surgeon. The different person said spasm of the vessel is not common. Study can potentially lead to over-exploration. Another said if the hand is well perfused with no disappropriate pain or new neurological deficit post-intervention, I will do nothing. Somebody said I have a paper on disappearing pulse in VIROC. Let us see what comes out of it. The evidence is all grey. AAOS guideline is inconclusive. There are no nice guidelines as far as I am aware of. Then there was a paper by Dr. Sabarwal. Maybe this can give you some ideas. Then I was told that I would keep the child well hydrated. I don't know what hydration means to the circulation. Oxygen in patient for 48 hours, look for that. And then I said everything is okay. Then there was a post that it is not uncommon to have absent Doppler in well perfused end. The collateral may be sufficient. The threshold to intervene should be low. I have seen well perfused CT angio showed occlusion of the brachial artery, and a vascular surgeon was involved in that case. Somebody said one exactly same case was seen. The child did absolutely well. There was no significant vascular neurological. So there are a lot of variations of opinion. Next day, if you see, there were no Doppler signals. The vascular surgeon had not seen the patient because he was busy operating. His nerves were normal. but the oxygen saturation had become normal by that time. So on that day, multiple opinions were there. Then I was asked again about the findings, and said that one of my vascular surgeon told the patient that the pulse is absent as my cavers are going through the artery. I had fixed the fracture, and then surgeon did CT angiogram and intervened. Fortunately, my vascular surgeon said that even if you do repair in a 6-year-old, it is likely to re-occlude. If he is doing okay, his SpO2 is 99%, you need not do anything. There were few more opinions asking what is the quality of whether the vessel is there in the fracture line or not. So I posted few more papers, and then there was another person who said, I have worked in USA, I have done so many things, my threshold to open is low. So when you get more and more opinion, you become more and more confused. Fortunately, I could refrain from doing any intervention. My vascular surgeon was also not keen. And after 1 week, you can see there was a good signal, and this is his 3 weeks follow-up with a good functional recovery. So Pink Pulseless Hand is a gray area. We do not have consistency among any treating doctors, but your clinical assessment, your setup assessment, and little bit of your experience matter in ultimately preventing a bigger surgery. Thank you very much.